Naše konference bude pokračovat přednáškou Boaze Wachtela, který bude hovořit o izraelském programu léčby konopím.
Okay, good afternoon, good morning, whatever, to everyone. Please, thank you. My name is Boaz Wachtel. I'm from Israel, with a wonderful group of people here that I see in the crowd. Lomir Hanush and other friends. And anyhow, we won't get too emotional to begin with. I will be talking about the National Medical Cannabis Programs in Holland, Canada, and Israel. We'll do some comparative analysis of the programs to make conclusions and to see how easy it is to make wrong decisions, usually by politicians, that affect the patients. And so let's jump into it. Holland, Israel, and Canada are the three countries in the world, the only three countries in the world. The Czech Republic will soon be the fourth that have a national medical cannabis program. That is in contrast to what's happening in the United States, that the cannabis programs are run by the state on a state level. And on the federal level or the national American level, there's resistance to medical cannabis, but it's still it's slowly being eroded, this opposition. And as we said, we are very pleased to see advancement here in the Czech Republic. I've spoken to some people, and I will refer to the program that you're going to have in the Czech Republic later on, because I see some dangers for mistakes there. What this slide basically says, this is the Single Convention on Narcotic Drugs in 1961. It relates basically to opium and cannabis. Most of it is for opium. So it regulates the medical use of prohibited drugs. And whatever applies in the UN Drug Convention to opium also applies to medical cannabis. Okay? So there's no much difference in that. What the basic model of the UN Drug Convention says is then that model can be replicated and used in other countries, is that basically you need a political will to launch it. The medical use of prohibited drugs is possible by UN drug conventions, meaning if you have a banned or prohibited drug, you can use it for medical use, and the clear road to do so, there's a clear road to do that. You have to set up a national agency to manage the national program. There are maybe 6 or 7 countries in the world that produce opium for medical use, for morphine and all the other opium derivatives. So they must have an opium agency. That agency would regulate the issue and make sure that everything falls within the boundaries of the UN Drug Convention. So the same applies. The same rules applies to opium and to cannabis. The agency, after it's established, after the agency is established, they must choose growers, issue a tender, a contract, and choose a number of growers. In Israel, we have right now 8 growers who have not been selected through this tender. A tender will be issued within the next few months in Israel. And here in the Czech Republic, you first go to the tender, you choose a few growers, and these growers would supply the pharmacies, and the pharmacies would give the patient, based on a doctor's prescription, the cannabis that they are going to use. So that is the basic model. There is no 2 models to that. And if a country wants to establish a medical cannabis agency, they should know that the model exists and they don't need to invent the wheel. and they just have to do as and has been done in other countries. So now what I wanted to take a look at is the number of indications in each country. On the left, you'll see in Holland. I won't go through the list of indications, but you can see that each country has a different list of indications that are approved for use. For example, in Holland, as you see on the left bottom side, the tics associated with Tourette syndrome. And some of them overlap, some of the indications overlap. In Israel, the PTSD has recently been added as an indication for use. So you see here maybe 1, 2, 3, maybe 10 major indications, and that is compared to the list that you can find on the Canadian National Medical Cannabis Program. So it's very hard to read, but there are a tremendous number of indications that are allowed in the Netherlands, in Canada. And the bottom line is, from my perspective as an activist and someone who's trying to help establish medical cannabis programs, is that it should be a decision by the physician when and to whom to give the medical cannabis program, and the government should not intervene with medical decisions by the doctor. Like doctors have the right to prescribe morphine to patients, so should every doctor should have the ability to give a prescription for cannabis, rather than as it is in Israel, that only specialist doctors can give prescription. Now I run quickly through the list of the countries. This is from the official medical cannabis in Holland. So they have different types of cannabis varieties available. We will talk about that. These varieties differ from each other in composition, strength, and also in operation, how they affect. The pharmacies, you can find 3 varieties from one producer. From Bedrocan, the variety is the most suitable. The variety that is most suitable for a patient depends on the symptoms and the reaction. The consultation with doctor determines the variety and the best choice. There's evidence that cannabis with combination of high THC and CBD provides multiple sclerosis patients good relief from pain. And this is the list of strains from the Dutch producer that they also export to other countries, basically in Europe, at a very high price, because they charge a high price, and the Dutch government also charge a high price, because the Bedrocan cannabis goes to the national agency, and the national agency supplies it either to individual patients in the EU countries, they can request it and buy it, or to supply it to another national agency in some other countries. So what we see here is basically a very limited number of strains. And as a result of the limited number of strains, or the selection of not such good genetics, we saw that in 2003, from 1995 to 2003, there was one supplier in Holland, a Mari Farm, and headed by Marcel David, who is here. We are honored to have him in the audience. Marcel, raise your hand. Who supplied, he was a Dutch pioneer who supplied to over 1,000 pharmacies a number of strains. And as you can see in the graph, there were about 10,000 patients at, you have no. So from 10,000 patients in 2003, it started to went down. It started to go down in 2004. There were 1,000 patients left, and it's been steadily rising. The reasons why the reduction is that as I said, the strains were not appropriate for all patients. They got used to strains from before. And in Holland, there's an option also to go to a coffee shop and buy some, if the price of the medical cannabis is too expensive, you can go to a coffee shop and buy some alternative. But it's not a good position for a country to be in, because the price of the medical cannabis has to be very low, and the patients don't have to go to coffee shops to buy medical grade cannabis that has to be grown completely different than recreational cannabis. This is a comparison of prices that between Canada, Holland, and Israel, and then we go into the extracts. In Canada, right now, it's $7 per gram for patients, so it's 210 for 30 grams. In Holland, it's $10 per gram. It was in 2005, and this is anyhow for export. It's $700 per export for 30 grams in Holland. In Israel, it's $100 per 30 grams. Okay, so we can see that the price per gram in Israel is the most reasonable. And on the right, you can see the pharmacization of cannabis, Sativax. It cost in the $800 per month. $800 per month, cannabis spray. And then there's the old-fashioned Marinol, which is synthetic THC. It's also very expensive, $678 per month. So the price is very important because many patients, besides the life falling apart because of physical illness, the economics are being damaged as well. They don't work and they make less money. So either the state should subsidize the cost of medical cannabis, or the national insurance companies, as is happening sometimes. Now we go to what's happening in Canada. Canada had a National Medical Cannabis Program that was filled with problems. In 2011, they decided to launch basically a new program. And the problem with the old program was, that is an example. I want to show you this picture. It's very difficult to see because of the light. But they awarded a contractor to grow cannabis in a mine, underground mine, 375 meters below the ground. And the mine was a zinc mine, an old zinc mine. It was previously used to grow flowers. Now, it makes sense if you want to grow flowers, just ornament flowers to put on your garden. You don't need these flowers, so you don't care how much zinc you have in the flowers. But if you grow medical cannabis flowers in the zinc mine, yes, then of course it will be laced with zinc for the patients to smoke. So that is an example of the, excuse my Canadian government friends that are not here, of stupidity of government decisions, because basically they chose the mine because of security reasons, and also because they don't have to engage in too much climate control, because the climate at 375 meters underground is a great temperature and there's no variations, so you can reach standardization relatively easy. So anyhow, it went on for seven years. It cost the Canadian government $10 million, okay? It cost the Canadian government $10 million. And I just want to go back here. Health Canada paid the company that produced the cannabis $328 per kilogram, and the patients were charged $5,000 per kilogram. So it's a 1,500% markup for the government on the back of the patients. Okay, so there's a danger here that the government would look at medical cannabis as another source of revenue and will tax it to high levels that will make it unavailable or unaffordable to patients. So it cost. For 9 years, they paid $10 million, the Canadian government, on taxpayers' money. It's a lot of money. It's almost anyhow, it's a lot of money, whichever. The key concerns, the key problems in the Canadian National Medical Cannabis Program was the complexity and the length of the application process. Okay, if you have bureaucracy and a patient who's a cancer patient who wants access to medical cannabis, and you start telling him, oh, go to this expert and bring us another opinion, and go to an oncologist, and this this individual that is, have many physical problems and other issues, have to go into a bureaucratic process. The bottom line, it has to be a simple process between the patient and the doctor. The patient should be reviewed, and then the doctor should decide whether he should get it as a first-line treatment, not as a last-line treatment. In Israel, when you have a pain patient, because pain cannot be measured objectively, it's a subjective symptom. Then they say first take all the other opium-based medications, and at the end of the year, if these opium-based medications don't work for you, we'll give you medical cannabis. So instead of going the other way around, first give him the medical cannabis, see if it works, because it's less addictive than opium medications, based medication. It costs less. You cannot overdose on cannabis, whereas on OxyContin and Oxycodone and all these medications you can overdose. So the other issues was that the efficiency of the timeline of the application was too long. There was one strain of dried medical marijuana offered in Canada, and other issues. I spoke with some Czech people the other day, and they said that in the Czech Republic, the patients are going to be offered one strain. So I said, how come it's one strain? They say the law has been formulated in such a way that they are allowed one strain. And if the Czech Republic will not change this law soon and start a national medical cannabis program based on one strain, you will have a failure. It has to be acknowledged, because the patients needs multiple strains. You don't know what's going to work for whom. And in Israel, we have about 100 strains, and in Canada, there's endless strains. You can grow as many strains as you want. So if there are patient groups here from this wonderful country, you should pressure the government to change the law and allow multiple strains to do that. So the new program is a simplified process where Health Canada does not receive application for program participant anymore. It goes directly from the doctors to the companies. A new supply and distribution center system. The multiple commercial growers that were chosen in a tender. These commercial producers will be inspected by Health Canada to see exactly what kind of quality control and procedures are in place, so the patients will get organic and clean and without any heavy metals and other pathogens on the flowers. They eliminated the option for home growing. There was a court case recently in Canada where the court says it still should be a valid option. So right now it's not clear. So also it has to be a physician-patient interaction. What's missing in the Canadian program, we will talk about it later, is the education part for doctors and the medical staff that is lacking in all other programs as well. This is a lot of text. I won't go too much into it. But this is the statistics from 2013. The number of persons who hold authorization in Canada of dried marijuana is 37,000. The number of patients for personal use for homegrown is 25 almost. The number of persons who hold designated person, it means that someone else is growing for them, is about 4,000. And so this is from December 2013. The numbers has grown since then. Few commercial growers in Canada went into production. For example, one company who went into production, the first 3 crops were the Ministry of Health in Canada says we cannot use them. So if it's not grown according to very rigorous standards, some growers would have to kill the crops and start anew, as they say. So what is missing from the Canadian National Medical Cannabis Program? It didn't allocate enough money for research. There's no element of patient education. In Israel, when you go to a patient receives a license, either he gets education from a nurse, or they have people coming to his home or her home to speak with them and instruct them for the beginning. It doesn't happen in the Canadian program. Physician and nurse education. What's missing else is guidelines for use in hospitals and old patient homes, and subsidies for the poor and health or health insurance coverage. And then the price in Canada is $7 a gram. Some people can afford it, some not. But once there's commercial competition, the price may go up. So they should put up a price cap on the number in Canada. So what's happening in Israel? Israel is the third country that have activated the National Medical Cannabis Program. We have in the audience the former director of the National Medical Cannabis Program, Dr. Yehuda Baruch. Yehuda, please raise your hand. Dr. Baruch, he deserves applause. Without his leadership and compassion, the Israeli Medical Cannabis Program would not have been as relatively successful as it is today. It needs fixing. There's an argument about the number of patients in the Israeli Medical Cannabis Program. Gil mentioned 19,000. So if you count the number of people who received maybe from the beginning until today licenses for medical cannabis, it may be true, but many of these patients are no longer with us. So the actual number is maybe 70 or 60%, am I correct, Neri? Of roughly so it's very vague on what the exact number of patients are. This is a slide I took without permission from Dr. Baruch. So you can see the rise of the number of patients in Israel from 2004, and it's still rising. What's interesting, Dr. Baruch wrote from the physician perspective that a lot of patients benefit greatly from the use. It's another medicine as an option to treat patients, higher safety than opiates. There's no overdose. And the other side effects that he mentioned here, that it's chronic pain clinics. People flock, or they go to pain clinics and they put pressure on pain doctors to receive it because, as I said, it is a symptom that cannot be verified because it is based on self-testimony, okay? And from a patient perspective, cannabis is better tolerated than opiates, no risk of overdose and death, different mechanism of work. It can help where other medications have failed, and it often does. It's a social trend. I don't believe it's a social trend. I think medical cannabis has been part of humanity for a few millennia. It has been subjected to prohibition and to government propaganda and smearing campaign of cannabis. And now medical cannabis, because of the work of many people around the world, has made a comeback, and its role in the modern pharmacopoeia is gaining again prominence. And then what strains to use and who decides, and should self-growing be allowed? In Israel, self-growing is not allowed. Now, in the UN model, it says that the National Medical Cannabis Agency should choose a body that would actually interact, a monopoly that would interact with the pharmacies, who would get the crops from the growers package it, and send it to the pharmacies. That was the vision in Israel. It's now in court, this move, that Sarel will be the monopolistic arm of the agency. We are not, the growers are not too happy with this method, because right now the growers in Israel wanted to be in touch with the patients, and the government said no, growers should grow, and the health system will take care of the interaction with the patients. These are the option consumptions in Israel: dried flowers, oil, brownies. In Israel, edibles are not allowed anymore for a very strange reason. Many patients prefer to eat than to smoke. The government said it cannot be measured, the doses of cannabis in the food, which is total nonsense. But sometimes governments make wrong decisions. Cannabis ointment, cannabis brownies is out of the question, and ready-made joints. And you see the Volcano vaporizer there. In Israel, if you go to an oncology department in hospital where cancer patients are lying down and suffering from pain, they can use the Volcano next to the bed. Okay? So that is a very, I'm very proud in that sense that in Israel, in a hospital, you can use medical cannabis until not very far back. People had to go to the yard, get out of the beds, and smoke in the yard, like thieves in the at night. So in Israel, when you give patients the cannabis, you make an interview, basic interview, what are you suffering from, how bad it is, for how long. We try to build statistical analysis, but it's very difficult to do that. It requires special people with statisticians to do a very good analysis. It doesn't always happen. So how do we improve the Israeli Medical Cannabis Program? Instead of only specialists allowed to give cannabis to patients, there's a limited number of specialists in Israel that are allowed, maybe 20 in the entire country. Not that it's big as Russia, Israel, but it's still 20 specialists. It should be a decision made by a general physician. That is my opinion. We need better quality control before the medical cannabis reaches the patients. We need good manufacturing practices and guidelines for cannabis cultivation, also GAP, and also ASA in collaboration with the American Herbal Medical Products and European Medical Evaluation Agency are building guidelines to guide the quality assurances around the cannabis growing. In Israel, for a long time, there were too much THC for the patients and not enough CBD. The Medical Cannabis Agency has today built with the growers and the patients a list of 12 categories, starting from high CBD to low THC and ending at the high THC and low CBD, and with a 30 or 25% spiel, how do you say, margin. I think that the national insurance companies should cover it, as you should insist in this country, because we said that it has to be affordable by the patients, and if the National Medical Cannabis Agency charges too much money, patients will not buy it. In Israel, the education in medical school for doctors is basically non-existent. There's now education for nurses, but there must be an integration of curriculum in medical schools and in nursing schools. And by the way, we don't have to invent this curriculum. In the United States, there are already online courses, continuing education, that you can apply to and take a course, but it has to be, in my view, integrated into the real core of the curriculum in medical schools. So allow for distribution through pharmacies, and that's happening in the near future, and increase government funding for medical cannabis research. It's always important. Now, this is a comparative view in Holland, Canada, and Israel. As you see right now, in Holland has 3,000 patients. In Canada, from the previous program, there are 40,000. In Israel, 14,000. So Canada is actually in a transition period. In terms of how the national programs comply with the UN drug conventions, yes, each country has a slightly different interpretation to the UN drug convention. In Holland, it's exactly how it's done with opium. The Medical Cannabis Agency is similar as the Opium Agency. In Canada, they changed it a little bit. There's commercial growing without the government having to take control of the crop itself. Yes, it goes directly from the growers, from the companies to the patients. And in Israel, it's relatively strict adherence to the UN drug conventions. So basically, we see that there's room for different interpretation of the model that we talked about before. Number of suppliers, it's a major problem. In Holland, there were 2. It went down to 1. Bedrocan produces relatively small amounts of medical cannabis. In Canada, there are going to be more than 20 commercial growers. In Israel, there are now 8 before the tender. After the tender, I don't know how many will left from these existing. The sale in Holland, the pharmacies. In Canada, it will be direct from the growers to the patients, okay? And in Israel, there's some home delivery, and in the near future, there will be in pharmacies. So patient education is lacking across the board. It's a very comprehensive issue, cannabis and medicine, and patients have to concentrate to learn about their specific disease and how it interacts with cannabis. What's good. And then patient organization in this country, as in other countries, needs leadership to represent the interests of the patients vis-a-vis the government. Because the government makes decisions, sometimes very bad decisions, and if the patients cannot approach the government and influence the program, then we have serious problems with the national program. So the number of strains, in Holland it's 5, in Canada it's unlimited, which is wonderful. In Israel there are maybe 100 strains, soon it's going to go down to 12. So if you don't have large selections of strains in your National Medical Cannabis Program, the program is going to fail. It's very simple. It's one strain cannot work for everybody. And research in Canada, in Holland and Canada, it's not enough. In Israel, there's a lot of research on medical cannabis, both funded by the government and private pharmaceutical companies or private companies. And there's some clinical trials. Now, this is from Reuters, just to show you the absurdity of the situation. There are Italian patients who want to buy medical cannabis. So where are they going to go the medical cannabis for? Where are they going to get it from? So they import it from Holland. It's the only country that produces cannabis and try to. So it costs for the Italian patient $38 per gram. This is crazy. 8 euros, sorry, 38 euros per gram. Now, who can afford 38 euros a gram? Now, the Italian solution, the Italians are being as wonderful as they are, came up with a wonderful solution. That the military, who's known for its security, will start growing medical cannabis for the patients, okay? To lower the price, okay? Now, there could be a problem with the drug stigma in a Catholic country and so on, that may keep the number of users low, but they went into a solution. The Canadian went for an underground mine, and the Italians for the military, you know? I mean, you can think it is such a dangerous act to the general public to grow medical cannabis. So it has to be done by the military or underground mines or soon in space. Maybe in the next time we'll be in a space station. So because the bureaucracy is so tremendous in Europe, so the legal cannabis costs 38 euros a gram. So in the black market in Italy, it's 5 euros a gram. So what it means is that patients went to the black market to buy it. So even when a doctor prescribes it, the state does not cover the cost, which it will cost the patient about $1,200 a month for a typical patient. As a result, when legalized medical cannabis arrived last year, only a few dozen people signed in Italy to do that. The health ministry, blah, 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 and so now they're changing it. So now I looked at, this is a very interesting slide, the price of cannabis in different parts in the United States. Now Colorado and Washington are two states that have legalized cannabis. So basically those who grew medical cannabis also became the producers of the recreational cannabis. So because if you look at Colorado, the retail legal cannabis is at $70 per 3.5 grams. Why is that? Because there's such high taxes imposed on the way by the state, on the growers, on the retailers, on the consumers, so it reaches the legal. The medical is still less taxed in Colorado, so it's about half, and the street value is very similar to the medical cost. In Washington, which didn't tax it as much as Colorado, there's less difference between the retail, the recreational, and the medical, and the street value. But still, if you look at the street versus the medical, some people would still prefer to buy it from economic reasons, to buy it from on the black market. So what I'm aiming at is, and that is the last slide. So this is roughly an estimation of cost to produce medical cannabis. It's a big question always, how much does it cost to produce medical cannabis? So indoors, it could cost you top $4 a gram. In greenhouse, it will cost you half of that. Okay, in greenhouse that is well managed by climate control and so on. But if you grow it outdoors, as we have here another American pioneer by Mike Corral, he can tell you, he deserves an applause also, gentlemen. He can tell you you can grow for $1 a gram. So if it costs to grow, okay, in this case it's outdoors. And patients need standardization. It's very difficult to reach standardization outdoors. We understand that. But if there's not enough money to put in the indoor operation, so you grow for patients, and he's been serving for 25 years patients from cannabis grown outdoors. And it went fine, right, Mike? It was 100%. And they had a collective, a wonderful collective, so for $1 a gram. So if in this country or another country, the price of medical cannabis, if they charge you 20 euros or $25 or whatever, you know, tell them you are thieves for taking so much money from sick people because it costs so little to grow it. Thank you very much. If you have any questions. No questions, good, we go home.
I just have a comment. You stated that it was hard to grow standardized marijuana outdoors. It's not, providing you have stabilized true to type genetics to begin with from seed. That's just a comment.
That's a good comment. That's a good comment, Mike. The genetics basically determine the stability of the strain, yes, but the weather also has some effect on the variability. Small, okay, small. Okay. Any other question?
Why do you consider it important for it to be standardized?
Who's asking?
I am.
Okay.
Personally, I'd like to see it growing everywhere, so people can just pick it and eat it or whatever they want to do with it. And it's a plant which will naturalize. It will, if you just grow the plant and take the seeds from that plant, and it will adapt to the environment for the best medicine for the person. Especially if they put the seeds under their tongue and then plant the seeds, they're going to get their DNA into the DNA of that plant, and it will get them the best medicine. If people grow it themselves, and to encourage more people to actually grow their own medicine and do it in community.
Yes, but if the state or wants to solve the medical cannabis supply issue, and the patients get a medicine, they have to know, because we are dealing with the medical establishment, and in the medical establishment they have an operational paradigm that the pill that they get today will be the same pill they will get in a year. You understand? It's a problem. Yes. And by the way, my the previous speaker, Gil Luxembourg, said something that I have to disagree with about smoking. We believe that smoking should be left as an alternative for patients, regardless whether you have other delivery options or not. Because what we are seeing actually is the pharmaceuticization of medical cannabis by big pharma companies who would slowly want to eliminate smoking, which is actually could be done in the cheapest way. So the smoking should be an option. In Israel, maybe 70%, correct me if I'm wrong, are still smoking, no, Neri? More than, so the smoking allows the patient to titrate. They take one puff to put it aside, and then if it works, they use another puff. So if they take a pill and it goes through the stomach, its effect takes a very long time. It's 30, 40 minutes to take effect, and then it lasts for 3 or 4 hours. Whereas the smoking, one puff can, pass the effect in 2 hours or 1.5 hours. So smoking is a very important alternative to keep for the patient to titrate their own medication. That is one reason they have to, even though it's not politically correct for the politicians, that cannabis smoking is an option for medical cannabis, then excuse me, the politicians, I don't want to say, something, because some of them are very problematic. So it has to be an option on the table, always in every national medical cannabis program.
Hello, Boaz.
Hello.
Eliza Walczak from Poland. You were talking about quality control in Israeli program for medical marijuana. I would like to ask if a medical marijuana program is also kosher. If Jews that are Orthodox, they can use medical marijuana if it's provided.
It's been kosherized. Luckily, imagine if it wasn't kosher in a Jewish state, the medical cannabis, we wouldn't have a national program. Luckily, it was and you can see a lot of religious people coming and and getting the medical cannabis, and it's helping everybody. It helps the Arab Israelis, it helps the settlers, it helps the Orthodox, it helps the secular. Cannabis it's not a racist plant. He can, he deals well with everybody. Any other question? Thank you very much.